Okay, order. I call this meeting to order. This is Standing Committee on Health. I'm Danny McGillivray, MLA for Pictou Centre and Chair of this committee. Today we'll hear from the Office of Addictions and Mental Health, Canadian Mental Health Association Halifax Dartmouth, the Nova Scotia Hospice Palliative Care Association, and the Mental Health Foundation Nova Scotia regarding Community Wellness Framework. Please set your phones to silent. Please be sure not to touch your microphone. The staff will help with anything you need for adjusting. Now I ask the committee members to please introduce themselves to the records by stating their name and constituency.
My name is Adegoke Fadori, MLA for Cleaning Parkwest, and welcome.
Welcome. I'm Susan Corkum-Greig, MLA for Lunenburg.
Hi there, I'm Ryan Robichaud, MLA for Clare.
Nick Hilton, MLA for Yarmouth.
Ian Rankin, Timberley Prospect.
Rod Wilson, Halifax Armadale. Thank you for coming.
Lisa LaChance, Halifax, Citadel, Sable Island.
Okay, thank you. And for the purpose of hands, I'd also like to recognize the presence of Chief Legislative Counsel Gordon Hebb and Legislative Committee Clerk Robin Dan. Okay, I'd like to welcome the witnesses and ask them to please introduce themselves. And we'll start maybe at the left.
Good afternoon. Thank you for having us here today. Francine Vezina, and I'm with the Office of Addictions and Mental Health.
Hi, I'm Kim Stewart. I'm the Associate Deputy Minister with the Office of Addictions and Mental Health. Thanks for having us here today.
Margaret Murray with Canadian Mental Health Association, Halifax Dartmouth Branch. I'm the Co-Executive Director and Building Bridges Manager.
I'm Beth Cadham, and I'm Co-Executive Director and Social Clubs Manager for the Canadian Mental Health Association, Halifax Dartmouth Branch.
Good afternoon. I'm Tim Guest. I'm the Executive Director of the Nova Scotia Hospice Palliative Care Association.
And I'm Starr Cunningham, the CEO of the Mental Health Foundation of Nova Scotia.
Thank you very much. And we'll ask for opening remarks. Maybe start with ADM Stewart.
Is this one? This one's mine? I wasn't sure. There's three here. Hi, everyone. Thank you very much for having us here this afternoon and for inviting us to participate. My name is Kim Stewart. I'm the Associate Deputy Minister of the Office of Addictions and Mental Health. And I'm happy to join you this afternoon to speak with you about mental health and addictions community wellness framework. With me is Francine Vezina, our Senior Executive Director, as well as 3 community organizations, all of whom do tremendous work in the community to improve access to addictions, mental health, and well-being supports here in Nova Scotia. The community will know that the Office of Addictions and Mental Health was created in 2021. And has been working since then to build a universal mental health and addiction system of care. When the office was formed, the team consulted with service providers, frontline workers, public health partners such as the Health Authority, Nova Scotia Health, and the IWK, people with lived experience about how we could build a system that works for all Nova Scotians. Using what we heard, a stronger, more connected mental health and addictions network is taking shape. One with more access points, fewer barriers, and more partners, including those from the public health care system, post-secondary institutions, the private sector, and community organizations. I recently joined the office as the Associate Deputy Minister, and I'm pleased to report that there has been significant progress made with the increased investment in public health care, more support for those struggling with substance use, and more support for youth through our anchor youth spaces that have been opening across the province. This is only some of the work that is underway. There's much more happening, like the supports and services funded under the Mental Health and Addictions Community Wellness Framework. Launched in 2024, the framework was shaped by extensive engagement with healthcare partners and community organizations. Now, through the framework, community organizations are receiving stable, multi-year funding. This means less paperwork and more time to do the work in the communities. Researchers are receiving grants to fund research focused on community wellness and the social determinants of health. And community organizations now have access to funding for shorter-term projects and initiatives. In total, we've partnered with more than 40 community organizations who now receive multi-year funding. There's 23 that have the multi-year funding. That was awarded last year with the announcement of the framework. We've provided many short-term project-specific grants which are administered by our partners at the Mental Health Foundation of Nova Scotia, who I'm sure will be happy to speak more to this in greater detail. We have also supported 4 research projects with more to come. This means more data and more information, more support for those who need addictions and mental health services and supports closer to home. Thank you for inviting us here today. I look forward to your questions and hearing from our partners here at the table with me about their initiatives that are making a difference here in Nova Scotia in people's lives every day. Thank you very much.
Thank you, ADM Stewart. I'd ask Ms. Murray, I believe, has opening remarks.
Inviting my colleague Bev and me today for this for this meeting to discuss the community wellness framework. Canadian Mental Health Association Halifax Dartmouth branch is a grassroots charity supporting the resilience and well-being of people living with mental illness and mental health concerns through our social connection programs and projects and the provision of information resources and advocacy in a space that is inclusive, safe, and respectful. We strive to create an environment of hope, to reduce stigma, and to promote mental health for all. We are part of a federated network of 330 independent Canadian mental health associations across Canada, united by a shared brand and vision, a Canada where mental health is a universal human right. Also in Nova Scotia, we're represented by 3 community branches because sometimes people are not quite sure how this operates. So we have 3 branches, Halifax Dartmouth branch, Colchester East Hants, and Southwest Nova. And we also have 1 provincial office, the Nova Scotia Division. So we respond to local community needs while working together to advocate for policy change and to strengthen mental health supports across the province. As is already mentioned, we were fortunate to be one of the recipients of a community wellness grant. Our initiative is Social Connection for Mental Health and Well-Being. And this grant, it really has provided much needed stability for us and an opportunity for growth during these very challenging times for community agencies. And to date, this funding has enhanced our current social connection programs and also allowed us to establish a new social well-being initiative as well as other activities. The other thing is, in addition, this has provided support to increase our volunteer base, which decreased during the pandemic. And I think we need to mention, too, that during the pandemic, certainly there was a light shone on loneliness and social isolation, and really made people more aware, which is something we've been saying for many years, and how devastating the impact can be on physical and mental health. And we certainly need to increase access to the right clinical care at the right time, but we also believe that mental health goes beyond treating illness and the social determinants of health. It's about creating the conditions where people can be well and stay well by addressing urgent challenges like housing insecurity, poverty, barriers to employment, suicide prevention, and social connection and inclusion. Our work has been guided by CMHA's framework for support for over 40 years to ensure that people live fulfilling lives in the community. And this closely aligns with the Office of Addictions and Mental Health Community Wellness Framework. It recognizes the role community-based organizations, First Voice and Loved Ones play in mental health and addictions care as we collaborate to achieve universal mental health care in Nova Scotia. Thank you.
Thank you, Ms. Murray. I'd ask, I think Mr. Guest is next.
Thank you, and good afternoon, and thank you very much for the invitation to join you today. Nova Scotia Hospice Palliative Care Association was established in 1994 to promote the philosophy and principles of palliative care through networking, public and professional education, advocacy, and research. Today, our organization has evolved, and we function as a provincial hub for equitable, compassionate palliative care and grief support, bringing forward the voice of community as we collaboratively work with community organizations, healthcare partners, hospice societies, providers, and government. Nova Scotia Hospice Palliative Care Association was selected in January of 1994 as the community hub organization to co-lead the implementation of the Nova Scotia Community Grief and Emotional Wellness Model with Nova Scotia Health. A component of our work in this role included the development of our Healing Pathways community funding grants to support not-for-profit organizations to implement community-led initiatives addressing grief, bereavement, and emotional wellness. This funding enables local organizations to design and deliver supports that reflect the needs, culture, and realities of their communities. To date, we've distributed more than $940,000 to 41 organizations across the province. An additional $700,000 will be distributed in March of 2026. Our second initiative, our Healing Pathways Grieving Well database, was launched in April of 2025 and is an online directory designed to provide information for individuals, providers, and organizations that are seeking supports, resources, and education on grief and emotional wellness-related care and supports that are community-based. And our third initiative that I wanted to mention for you today is a collaboration with Nova Scotia Health, where we launched the Nova Scotia Grief Alliance in the spring of 2025 to bring together partners across sectors to support networking, education, collaboration, and shared learning, with a particular emphasis on strengthening the knowledge and confidence of those providing grief and emotional wellness supports in communities from across the province. At a time when the need for these supports is greater than ever, we remain committed to strengthening grief and emotional wellness across the province and appreciate the opportunity to discuss our work with you further. Thank you.
Thank you for that, Mr. Guest, and we'll ask Ms. Cunningham.
Thank you very much for inviting the foundation to be here today. I'm excited to talk to you more about the work that we do across the province. So the Mental Health Foundation of Nova Scotia is the province's only health foundation that's solely dedicated to fundraising for mental health and addiction support. We exist to improve the mental wellness of Nova Scotians by granting funds to community-based mental health and addictions organizations, and our vision is to see all Nova Scotians thriving in their communities. We believe in community because connection, belonging, and circles of support are fundamental to advancing mental wellness. We believe in compassion because kindness and understanding create nurturing and inclusive environments for growth, healing, and recovery. We are accountable because we exercise responsibility, oversight, and care for the lived experiences, relationships, and funds that are entrusted to us. Our granting programs are at the heart of everything we do. Through the lenses of education, peer support, community, and connection, we fund programs from Yarmouth right down to Sydney and everywhere in between. We have 5 granting programs, with community grants being our largest. In 24-25, we awarded 375 grants, totaling just over $4 million. Community grants accounted for 158 of them, totaling just over $3.2 million. Much of that funding is provided through the Community Wellness Framework, allowing us to provide more mental health and addiction support access to Nova Scotians where they need it most, and that, of course, is closer to home. The Foundation is incredibly grateful for this funding, as we see it as an important step toward achieving universal mental health care. We provide the office with regular reports 4 times a year, which highlight the area of impact, geographic location, number of Nova Scotians served, and financial details. The Foundation is really in a unique position because every grant application we receive tells us a story. It shows us what's working and what's missing in each community. It's also timely and relevant because we call for grant applications every 6 months. So we really have a pulse check of what's happening in the field of mental health and addictions across the province. We receive hundreds of testimonials from Nova Scotians, and I wanted to share one with you that really captures the essence of what we do. This is a quote. I have made lasting friendships with people who have quickly become my go-to supports. The program has helped me feel less alone, more informed, and more connected, both as a caregiver and as a member of my community. Together with our individual and corporate donors, other foundations, community groups, and the Community Wellness Framework, we invest in projects that connect people, increase resilience, and offer hope to create a future where every Nova Scotian has a chance to thrive in their own community. Thank you.
Thank you very much, Ms. Cunningham, and the rest of the members for their opening statements. So we're going to move on to the question and answer period now. Each caucus has 20 minutes, plus a second round of approximately 10 minutes, as time allows, and questioning will wrap up at 2:50. So we will start with the NDP. MLA LaChance.
Thank you so much, and thank you to everyone for being here. This is such a critical topic for our province. In 2021, this government promised universal mental health care. And the minister responsible for the Office of Addictions and Mental Health has said, and I have a quote, "No matter where you live in the province, no matter what issue you might be facing or illness you're living with, you can get the mental health and addictions care you need for free as part of our publicly funded healthcare system." And the universal mental health care portion of that was launched last year. We have a Freedom of Information request from December showing that 27 private practitioners signed on to deliver publicly funded universal mental health care. I'm wondering, does that meet your target of practitioners for this program? And I'll direct that to Ms. Stewart.
ADM Stewart?
This turns on automatically.
Sorry.
Thank you for the question. Yes, the work that we're doing at the core of the access to universal, or I guess access for Nova Scotians to be able to access the care they need anywhere closer to home in the province. We're doing that through the community wellness framework, but specifically to your question about the 27 clinicians, we have launched an insured services program for those for mood and anxiety. That was launched in August, and we started taking appointments early in September. And what we're focusing on, there's been 1,000 more, just under 1,000 appointments, more appointments that have been available to Nova Scotians. This is through private clinicians. That's the insured services program, is to I guess align and work jointly with the public service to try and address some of the backlog we have in the system. So there have been 1,000 more appointments. We are working to onboard more clinicians, but we're trying to do it at the right rate. We're working closely with our partners in the health authorities to ensure that we have a community of practices being developed to ensure that the work between the private clinicians and the public clinicians is aligned. So we are making strides in that area. 1,000 more appointments to just about 400 individuals.
Thank you. MLA LaChance?
So of the 27 signed on so far, only 2 are psychologists. There's 8 social workers, and the rest are registered counseling therapists. And I'm wondering, how does this reflect the level of care that's needed in the community? And you mentioned a community of practice, but I'm also curious about what other steps are put in place to ensure patient safety, so that if folks show up at the doors of a registered counseling therapist but need significantly higher levels of care, what happens then?
ADM Stewart?
Sorry. I appreciate the need to ensure that the appropriate level of care is being provided. I'm going to ask Francine to comment a little bit more detail on that, and we're exploring options for those individuals.
Ms. Vezina?
Thank you for the question. The onboarding of the various clinicians, not only is it kind of the most important part being about the number of clinicians, but what we're looking at is mood and anxiety disorder, and we're looking at the non-urgent wait list. So what we recognized that we needed to do was to reduce the wait times for those folks who are waiting for the non-urgent appointments and lower that down to 28-day wait time. So in order to do that, the creation of more appointments for folks is what we're looking at. There's also a system, an IT system in place for us to be able to book those appointments and to do the piece which you're referencing, which is our measurement-based care. So looking at the outcomes in real time with those clinicians, not just in the Nova Scotia Health Authority and the IWK, but also we are incorporating that into the insured services program to make sure that we're getting the same quality of care for all individuals in Nova Scotia, regardless of where they're accessing their mental health and addiction supports.
MLA LaChance?
And so how do patients access this program? How are they getting triaged? Do people have a primary health care provider, and kind of what happens at the end of a set treatment course? And, what happens if they need a psychiatric consult? How does that, are they back on the wait list for that and have to scroll through all of that? Or tell us, I think it's not clear to Nova Scotians how to access this, so.
ADM Stewart?
I will get it. There are many access points. There is, for individuals, they can self-refer through a central intake line. They can come in through the community organizations. That's part of what we're here to talk about today is the community wellness framework. That is a point of access as well. They will be assessed and to determine what the appropriate level of care is for those individuals. It may be in the community organizations. It may be with clinicians. It may be in the public system. So that is really at the core of what we're trying to do with universal mental health is to have different options for different people. People need different types of care. There's virtual options, there's in-person options, but also to bring it to the community for individuals who understand the needs of their community better to make sure it's culturally.
Order. MLA LaChance is satisfied with the answer. MLA LaChance.
Thank you so much. Francine will know that I never come to these meetings without a long list of the wait times and the wait time trends in mental health in Nova Scotia. And, you know, I think a couple things. One is it's not stabilized. So, I mean, in non-urgent care across the province, and I think if we went through quarter by quarter over the last few years, we'll see an advance in sort of the wait time, you know, the 50th percentile for the first appointment, and then we'll see that disappear. And we'll see wait times increase again. And, you know, across the province, I mean, wait times for non-urgent care are still exceeding any, you know, sort of evidence-based target. So folks who might access this universal mental health care, they would be part of the people who are on this wait list, and then we get screened in. So folks who come through a community-based organization, they also get put on the wait list.
Ms. Vezina?
There was a couple questions in there, so just repeat one if I happen to miss one. So with regards to the access to it, so to back it up just a little bit, if folks call central intake, because everything, what was really important was to ensure the integration of what we're adding on to the system with the existing system to create this one universal system. So calling the intake line, folks will be triaged. And if there is the inability to provide appointment in the public system within the 28-day wait time, folks are offered an appointment with a private clinician. They can accept or not accept. They're not obligated to take one or the other. And that would be targeted to be able to get to see them sooner. So that's sort of the entry into the system. With regards to the wait times, unfortunately, we're always a quarter behind on the wait time. So the wait times that are currently posted on the public website would be the last quarter and not the current quarter. So if I remember correctly, I think the end of January, the next will come out. What I do know...
Order. Thank you.
I'm just going to stop.
MLA LaChance.
I'm sorry, I'm just going to stop you there just to try and advance the conversation. As you know, we never have enough time. And so, I mean, this is the public data that I have available. This is the public data that Nova Scotians have available to understand how it's going, to understand how long they would wait for appointments. And so when across the province, Nova Scotians are actually waiting longer for non-urgent mental health care than they were 2 years ago, if you look at the trends. And in the, looking at this, it's, the vast majority of, in the last reporting period, there were four jurisdictions where you met that 28-day target, and the rest you didn't. So for the 50th percentile first appointment, which is that screening appointment, Dartmouth Portland Street Clinic, 142 days. CVRM, 134 days. And I'm not suggesting that anyone's happy with that, because what we know is that people get sicker the longer they wait for mental health treatment. But why are we seeing Nova Scotians having to wait longer for the care that they need?
ADM Stewart.
To your point, to Francine's point about the stats and the availability of data, since that data was released, we have had 1,000 more appointments coming online to Nova Scotians. And as she also said, they have the ability to choose between a public practitioner or to go into the private insured services. And that will only continue to grow. So we've the numbers every week, when we see different numbers, it's growing. So I am confident that there will be more appointments available to address some of those wait times. The data that we're seeing, that we are reducing it. There is still a wait time, but we are working to reduce it.
MLA LaChance.
And I'm wondering, where did the 27 private practitioners who enrolled in the program come from? You know, when this was launched, there was a lot of concern that, you know, we have vacancies in the public system, that there's not, certainly for psychologists, and that most private psychologists at this point don't have room for additional caseload. So where did they come from? Were they public? Were they private? Did they come to Nova Scotia for this program?
ADM Stewart.
Are currently in private practice in Nova Scotia, and the 27 clinicians, it's what we're focusing on. The appointments available is a better measure because they provide a minimum of 10 appointments per week, and that's mandatory. They have to make available, so they're doing it on the side of what their private practice already is in addition to, and they're making that many appointments available. So that's how we're focusing on the number of appointments, because some of them can actually do more, some of them do the 10. So that's how we're focusing on the appointments. There's a criteria that's been put in place to ensure that, again, the standard of care, to select, there's a rigorous process. We have a coordinator who's in the office, who's a clinician herself, who oversees all of that and is running the community, is overseeing all of the work to ensure the quality and the alignment with the public system.
MLA LaChance.
And, you know, I had asked what happens when folks who are trying to seek mental health care in this province are on the wait list, because there's still a wait list for all non-urgent care. Do they have a primary health care provider? And if you know, a clinician completes within this insured services, you know, a block of service, like an 8 or 12 session program, what happens to that person then? Who does follow-up? How do they get follow-up?
ADM Stewart.
One of the ways is there's been the rapid access to psychiatry program that has been rolled out, and that is one way for those who are in the most urgent need. Their physicians can connect in through that program and be put into more immediate need with a psychiatrist, and that is one way we're trying to deal with the most acute cases. But there are many access points. We have an Access Wellness program who's run by the Nova Scotia Health Authority. There are in-person sites around the province. There's virtual, there's phone, there's capacity in that. There isn't a continuum of care, but it's the ability to call and to speak to someone fairly soon, like that one clinician. That's a service that's available through our Your Health NS app. There's a lot of information there available as other services and supports that individuals can access while they are waiting.
Thank you. MLA LaChance.
I mean, I appreciate that answer. You know, I still think that Nova Scotians are concerned that you know, the type of ongoing care you need for, a long-term mental health concern. If you don't have a primary care provider, it's very hard to access, for instance, prescriptions and the prescription renewals. Like I'm approached by people every week who cannot, through the virtual care NS, have their prescriptions renewed. And so what that also means is that people are not going to stay well. So this is just, it's just creating a system where we invest, people have access to a service, and then there's some backsliding. And so, I guess that's my question, and I'll leave that question for now, but it's really not clear to me how people will get the type of follow-up service that people need if they don't have access to primary health care. I wanted to give some time and turn to some of our community associations who are here. And perhaps I'll start with the Mental Health Foundation of Nova Scotia. We looked at, there was some data over the holidays that was released that showed Nova Scotians being less satisfied with life than the average Canadian. With the everyday Nova Scotians that you interact with, that your partners interact with, what needs do you see in the community that are currently unmet? And what are the service gaps that you're seeing?
Ms. Cunningham.
Thank you very much for that. In my opening statements, I commented that every grant application tells us a story. So it shares with us what is working in the community and where some work needs to be done. And we review that and kind of pull out some main themes. And the main themes that we've seen in the last 6 months into the last 12 months have been mental health supports for caregivers, so the loved ones and the people who are taking care of the people who are struggling with their mental wellness or living with mental illness and addiction. We've also seen more applications identifying newcomers as an area of the population struggling to access mental health and addiction services. And it's interesting, bereavement has been more on our radar in the last really 18 months than it ever has before. So we're hearing from more communities and individuals who need help dealing with grief. Perinatal health is also on the list for the first time. We have had some grant applications in that field before, but we're noticing more of them now. And the other one I'd say is IPV, so intimate partner violence. And I don't think that's a surprise to anyone in Nova Scotia, but we have been seeing more applications for organizations looking for more support funding the mental health and addictions component of that.
MLA LaChance.
And I guess the second part of the question is, so those are the trends, that's what you're hearing people needing support with. Where do you see the biggest gaps in services? So when people come to you and say, we want to support survivors of domestic violence, but...
Ms. Cunningham.
Thank you. I think it's in easy, accessible mental health counseling. So it's people wanting access to services in their community when they need the services. So it's about easier access to that one-on-one counseling as opposed to peer support is fantastic, and we support a lot of it, but we do see a growing demand for one-on-one counseling, and we do provide funding to organizations. I think of Coach of Hope, for an example, which operates in Dartmouth and provides free counseling to people who don't have private insurance and can't afford, and other organizations similar to that across the province.
MLA LaChance with 2.5 minutes remaining.
Great. When folks are waiting, so when folks can't get access to that counseling that they want and that they probably need, what happens then? What's their experience then?
Ms. Cunningham.
We do our best to connect them with services that are in their community, so with community organizations that are providing the work. We also provide them with resources. We're not mental health clinicians, so unfortunately we're not able to help people directly with their specific problems, but we are certainly able to put them in touch with other organizations and other departments that do.
MLA LaChance with the 1 minute 50 seconds remaining.
I'm actually going to hop back to the office just quickly, hopefully an easy question. Just following up on the meeting on integrated youth services and the Anchor Youth Services program in Nova Scotia. So I'm wondering, the expectation was there'd be an additional site up and running by January 1st. I'm wondering if that's happened and if you could confirm the level of service that has been found through Anchor programs in terms of numbers of youth or numbers of hours.
ADM Stewart, 1 minute 20 seconds remaining.
There are 3 sites up and operating now: Halifax, Amherst, Halifax, Amherst, Sydney. Apologies. There's 5 more that are opening. There's 5 more that are planned. There's a second one in the HRM, Bridgewater, New Glasgow, Eskazoni, and Yarmouth. There are plans for those to be opening before 2027. My understanding is the uptake, I can get specific numbers for you, but the uptake has been very good at the youth anchor sites. I went to an opening in August myself, and I was really blown away at the participation of the youth and how they showed up and the collaboration that has been done in the communities with those youth. And one of the things they said that really struck me was in the opening remarks is all the youth have to do is get here. And by getting there, there's so many onboarding ramps for them to access clinicians, we hear in Amherst that one of the things that they're accessing is the washer machine. So to be able to come in and wash their clothes, the life skills, the assistance having jobs, school support, but also, again, the mental health supports, the counseling, and some navigation to help them access the various things they need in the system.
Thank you, MLA. Chance, there's 4 seconds left.
Thanks, folks.
Move on to Liberal Caucus and MLA Rankin.
Thank you, Mr. Chair, and I want to thank everyone for the important work they do in such an important field, especially with the growing issues that we're seeing in mental health and addictions. But I'll ask a revenue question first to the Mental Health Foundation, if I could. I know parking has now been made free for visitors to the hospitals, and I'm just wondering, in terms of that revenue that foundations have counted on, is that now streaming to the foundation to ensure that there was no revenue lost to meet the commitment from the government?
Ms. Cunningham?
My understanding is that there is not a revenue stream replacement that's in place. The Mental Health Foundation of Nova Scotia did receive funding from parking revenues, but ours were never high enough to really impact our bottom line much. But I know there are other hospital foundations across the province who relied on that money, and it's my understanding that they have not received any funding to make up what they would have received had parking not been free.
MLA Rankin?
Thank you, Mr. Chair, and maybe I can redirect to the government representatives that are here. I think, it's an important commitment. I think the Premier himself made it that he would make sure that he would keep those foundations whole with revenue that has been missing, and obviously they do important work. I don't have to reiterate that. So if you could give a timeline to the committee on when that revenue will be replaced, or if there's no longer that commitment.
ADM Stewart?
I'm not able to provide specifics on timeline. That is something that is really with our partners at the Department of Health and Wellness, but I'm happy to take that back and to find out.
MLA Rankin?
Okay, I think that's disappointing to say the least. This is really important work that I think all the members on the committee want to see continue with the foundations, and if you could get back to the committee or the Department of Health, if we could ask to get answers on.
I can confirm that.
ADM Stewart?
I can confirm that we have recently signed an agreement, though, with the Mental Health Foundation of Nova Scotia to extend our agreement for an additional 3 years, so that has been recently signed. But I appreciate what you're saying.
MLA Rankin?
I appreciate that. And something that stood out to me in opening comments, Associate Deputy, is that there's a statement that there has been a significant progress in increased investment in public health care. That's a significant statement in the context of Nova Scotia, because historically those that follow public health funding is that we have been laggards, and this is not political. It's been the case in Nova Scotia compared to other provinces as a percentage of the health budget. So it's been hovering around 1 to 2% for a long time, and experts think that we should be getting closer to around 5%, like other provinces spend. And so, can you quantify that statement that there's been increased investment in public health care? We heard today about an increase in health spending overall of 50%. So this is kind of a budget question, but also asking the department to actually prove that there's been an increased focus out of the $6 billion being spent on healthcare. How much is a percentage is Nova Scotia spending now to back that statement up?
ADM Stewart?
So our budget is $363 million. That's the biggest investment in mental health and addictions in history of our province. The majority of that budget does go to Nova Scotia Health and the IWK for the public system. With respect to community, we are investing about just over $30 million a year in community options and access points within the community.
MLA Rankin?
I guess when I read public health care, what it says to me is like preventative health care for community-based care, and trying to help with the whole wellness relative to the topic today. And correct me if I'm wrong, maybe you're speaking more with this statement that it's dedicated money for publicly funded health care is maybe the more appropriate statement that I'm reading from the intro. Okay. I'd like if you could provide to the committee, I think experts really in this field are interested in what Nova Scotia is spending as a percentage of the global health budget on preventative health care, because it has been something that I think we can all agree that Nova Scotia can catch up on. Is that possible?
ADM Stewart.
So when you say as part of the preventative health care, are you speaking more broadly about health care or specific to mental health?
MLA Rankin.
Yeah, sorry, Mr. Chair. The whole gamut of preventative health care, treating the wellness as opposed to treating the illness, and ensuring that we are upstream investments in preventative health teams and community-based health care.
ADM Stewart.
I can speak to the mental health aspect, the mental health and wellness aspect of that. And what we are trying to do with the community wellness framework and that work is really invest early on in the community that is focusing on mild to moderate, so that individuals, we hopefully are able to treat them and provide them with the care they need before things escalate to that. They do need the formal system, they do need the clinicians, but those organizations are then able to refer in as needed for that more formal care.
MLA Rankin.
Okay, yeah, that's fine for today. Whatever information you can provide, that'd be great. I want to talk about youth mental health and children's intensive services and adolescent intensive services. We have day and inpatient programs for youth under 19 with mental health and substance use disorders. So I want to ask first, how many CIS and AIS beds do we have as a total aggregate in the province?
ADM Stewart.
I'm going to refer that question to my colleague, Francine.
Ms. Vezina.
Hi. I'm sorry, we don't have the data, that information with us today. So the number of beds and the data with regards to the acute care, mental health and addiction system, we can get back to you and provide that information.
MLA Rankin.
Okay, that's interesting. Can you at least say how many beds or if there are any beds outside of Halifax?
Ms. Vezina.
Any AIS or CIS beds outside of Halifax? No.
MLA Rankin.
And can you say if any beds are available on weekends?
Ms. Vezina.
For the AIS and CIS programs, they run Monday to Friday. But they are, although those beds exist in Halifax, they are provincial. It's a provincial service.
MLA Rankin.
So given that it's a provincial service, is there transportation available for those living in outside of Halifax to get to those beds?
Ms. Vezina.
Yes, if families speak with the care teams, then they have a variety of ways or resources available to them.
MLA Rankin.
Would that include services to be able to get those patients back home on weekends, given that they're not open, those beds aren't open on the weekends?
Ms. Vezina.
I can't speak to specific parameters, but what I do know is that they have supports available to support travel for family and the individuals accessing the service.
MLA Rankin.
Thank you, Mr. Chair. And I understand from staff that are working at these facilities that the work is obviously very challenging and, could become a bit of a safety concern. So I'm wondering if there's security provided at these places to help with staff concerns.
Ms. Vezina.
They do have access to services available through IWK facility or the organization itself that they can draw on.
MLA Rankin.
Thank you, Mr. Chair. My understanding is that there is not security services available. I'm wondering if you have the data on the longevity of the staff working in these types of environments, if you have that, how long staff are actually staying working in this field.
ADM Stewart.
We do not have that data. That's something we would have to work with our partners at the IWK. They are operationally responsible for these areas, but we can get that information and get it back to you for sure.
MLA Rankin with 10.5 minutes remaining.
And so do you track any kind of data? Again, my understanding is this is a field that is very challenging to work in and has retention issues. So do you have the data to show the kind of retention that is available in this field? And can you provide that kind of data to the committee?
Ms. Vezina?
No, we don't have that here.
MLA Rankin?
So is the department saying that they don't track any data in terms of staff feedback or anything related to working in this field at all?
Ms. Vezina?
Absolutely, we collect all of that data, but the majority of the data that we would have brought with us today would have been focused on the community wellness framework.
MLA Rankin?
Maybe I can ask when patients turn 19, I think this is important with the transition into the adult health, mental health system. What are we doing to ensure that the work continues and that there is a smooth transition into the adult-related field?
ADM Stewart?
We work collaboratively with the IWK and the Nova Scotia Health Authority in the work we're doing to provide the access, the universal access that is our mandate to do. We have a steering committee that is composed of myself and VP at the health authorities, and we work very collaboratively on all of the different services being provided. The health authorities are they are operationalizing this, but we provide policy and direction, and we do connect on a very regular basis, and that is something that is very crucial and part of the discussions we have at that level.
MLA Rankin?
Thank you, Mr. Chair. And we know that a lot of this this issue relates to homelessness. And I want to ask the department if they track whether this program effectively lowers the risk for homelessness for its participants once they've gone through the program. It's said that there is some data that's tracked related to staff. I would think that this would be a very important piece to ensure that we're doing all we can to gauge the effectiveness of the program, if we can limit at the end of the program, if we see Nova Scotians without a place to live.
ADM Stewart?
We have seen there are raising numbers of homelessness. It's becoming more visible. That is a trend across Canada, and we are working closely with our partners in the Department of Health and the Department of Opportunities and Social Development and the health authorities. In terms of we have a mobile outreach unit. We're working with the North End Community Center here in the HRM to provide those services to those. Through our community wellness framework, we are funding a number of organizations who are working with those that are unhoused, that have the concurrent mental health and substance abuse issues, and it is something we are working with. It's something that as government we can't do as an office alone. We really have to work, not have the silos, and work across the various departments to address this need.
MLA Rankin with 7 minutes remaining.
Thank you, Mr. Chair. So when the framework was announced in the spring of 2024, it didn't really come with a budget. And so since then, we've had some announcements roughly painting a picture of how much is being spent on the program. But perhaps for more clarity, how much was initially budgeted for each of the three funding streams? So you have the project stream, the MHA Community Wellness Grant, and the research and innovation stream.
ADM Stewart?
So for the multi-year grants, which is the community wellness grants, we provide just over $4.5 million per year over 3 years. For the one-time grants, that's $1.75 million that goes to the Mental Health Foundation of Nova Scotia. Again, we just signed a new 3-year agreement with that organization for 3 more years of funding. And through the project stream, for the research and innovation stream, there's $400,000 that was awarded to 4 different organizations. Now that's work we do with Research Nova Scotia, and just yesterday we announced that there would be $400,000 more available to more projects. That's specific to the framework, but the broader amount that we spend annually in supporting work and the work in the communities is about just over $30 million.
MLA Rankin?
And is there another cohort of applications that will be opening up soon for this program?
ADM Stewart?
For the framework or a specific stream? For the project stream. I believe there is. There will be another call for applications, but I'm going to defer to partner at the table who can speak in more detail to that.
Ms. Cunningham?
Our grant applications are open right now, and they close coming up the 3rd week in January. And then we'll be scoring, our committee will be scoring and reaching out to successful applicants by end of March, early April. And then our grants will open again. So every 6 months, we're opening a new call for grant applications.
MLA Rankin, 5 minutes remaining.
Thank you, Mr. Chair. So the Guerin family announced $25 million to the IWK in 2024, earmarked for intensive services for children living with mental health and addiction. Do we have a timeline proposed for the mental health and addictions ecosystem at the IWK?
ADM Stewart.
I do not have the timeline for the longer term. I know significant investments have been made in the Guerin Centre. I recently did a tour of it, and that is a place for youth at the highest, the tier 5 level of care that come from across the province, and that there has been, some of the money has been used to invest in that site. As for the remainder of the donation, I do not have the specific timelines, but we can get back to you.
MLA Rankin.
Thank you, Mr. Chair. And along the same lines, the funding was announced to be intended for that increased intensive rehabilitative, more inpatient care that can only be possible with those inpatient units. So I'm just wondering if you can give an expectation of when the inpatient beds for children will be ready, for children and youth will be open at the IWK.
ADM Stewart.
I believe those beds are already available in the Guerin Centre in the IWK. The capacity has expanded there. I cannot say the exact number, but I will find out. But I believe that those inpatient beds have already been expanded.
MLA Rankin.
Okay, thank you very much. So when the Mental Health and Addictions Community Wellness Framework was published, it included a list of intended outcomes with indicators and the method of data collection for short, medium, long-term projects. Data collection methods included community-based organization surveys, data from Stats Canada, CAHA information, and Engage Nova Scotia Quality of Life Survey. What time periods are being considered for short, medium, and long term?
ADM Stewart or Ms. Vezina.
So we're early yet, so most of the community-based organizations received their funding at the end of March, beginning of April in 2025. And so we would be looking at, yes, short, medium, and long-term goals. What we do collect from them are quarterly reports. We have a dedicated community liaison position that is new and is involved in the accountability and collaboration and relationship with community-based organizations, so that is also strengthening our relationship. They provide annual reports which speak to the indicators that you are speaking about that were in the logic model. And so once everyone has completed their first year of funding and have the opportunity to complete their final reports, what they'll do is submit them to the department, and we'll be able to measure them up and report back on them according to the logic model or evaluation plan, and talk about those indicators and outcomes from the Community Wellness Framework grants.
MLA Rank with 1 minute 45 seconds remaining.
Okay, the longer term indicators of outcomes will be largely based on the Engage Nova Scotia Quality of Life Survey, and according to their website, the 2025 survey has been postponed. If this survey is being delayed, how is the department assessing the outcomes and indicators of the funding?
Ms. Vezina?
So we have an evaluation plan that is specific to our universal mental health and addictions continuum, and part of that continuum is the community wellness framework. And so we will work with within the office to look at those indicators and to measure them using the data that we receive from the community-based organization until such time that the survey takes place.
MLA Rank with 55 seconds remaining.
Okay, no, I think I'm good for now. I appreciate the answers. Thanks.
Thank you. So we'll move on to the PC Caucus. We'll start with MLA Hilton.
Thank you, Mr. Chair, and thank you, everyone, for being here today. My mind is always working, especially when you're having so much great conversation and input on what's going on in Nova Scotia right now when it comes to mental health and addiction. I spent, well, a good part of my nursing career in and out of the mental health and addiction departments in the Yarmouth Regional Hospital, and we've seen a lot of good things happen, some decline over the years, but recently a lot more improvement, a lot more good conversations, specifically around the community wellness framework and some of the organizations in our community that have been funded. Yarmouth is well represented on the grants list. And I'll probably have a few more questions for you a bit later, but just, I know we've been focused on the department, just a couple to the department to begin with. And I will say, you know, around wellness and prevention, it's nice to talk about that because normally in healthcare we're focused on the disease, and at that point, you don't see a lot of cost savings. So to work on wellness prevention, talk about things like the Integrated Youth Services Hub that hopefully will have a grand opening for in Yarmouth sometime in the next year, 1,000 more appointments. Believe it or not, free parking at the hospitals was a positive thing, and hopefully we'll work all that out as well as we get moving along. Could the department, could you please outline the various streams of the community wellness framework and how they work together to advance community-based and universal mental health care?
ADM Stewart.
The community wellness framework, as I've said previously, is really part of our commitment to develop universal access to mental health and addictions care. So in the communities, closer to home for individuals, where the communities understand the needs of the people that live there. Again, early intervention, provide the services early before it escalates and more intervention is needed. But really it's about providing more access points. So there's more ways to access the various services. Government is also we're leveraging the skills of the universities and the post-secondary institutions. We're working with our partners, again, in those community organizations, but also with the public system. The three areas we've spoken about, the project stream, the longer-term funding stream, and the research. So what we heard through all the engagement that was done in developing our universal mental health strategy and the community wellness framework was that these organizations, this is probably true of many sectors, these small community organizations, they spend a lot of time writing grants to government to access money. So really at the core of this is providing the stability so that they're able to hire the staff they need, have a little bit of predictability over 3 years. They're able to do the work and now we've put the appropriate accountability in place, so with the reporting that Ms. Vezina has spoken to earlier. But that really is the aim of that group. That stream is to provide that stability. The project fund, which Starr Cunningham can speak more to, is to focus on those individual projects. Are there specific things that can be done in a certain area to enhance a mental health support, to complement, again, the longer-term funding? And the research works together to, again, inform all of this work.
MLA Hilton.
And just thinking about how we got to this point, what is the differences with this type of framework versus what we were doing before? Were we doing anything to move to a more, to the easy access of care, early intervention, the wellness side of things? What are the positives that we're doing now?
ADM Stewart.
One thing that we are doing is the office has been funding these community-based organizations for a long time. The community wellness framework is a new way of doing it. We are working to bring some of the historic work under, so there is an alignment and the accountability is in place for all of those organizations. That's one of the primary differences. The other difference really is, again, it comes back to the system of care that's being created so that it's all working together in tandem, so that those who are accessing the services at the community level, having more access points for those in the rural communities to then feed into the larger, more public system.
MLA Hilton.
Thank you. In your remarks, you mentioned your department is investing in more than just community-based organizations to build universal access to addictions and mental health care. Can you kind of just give some ideas or suggestions on what those other organizations are and besides the integrated youth services hubs, is there anything specifically we're doing to support young people specifically?
ADM Stewart.
One of the things that I can speak to that is in community, but outside of the framework, is we are funding in 7 different communities. We are providing funding for clinicians to be in the communities. So that is one area. The insured services program that we spoke about earlier, that is also available for youth, to your question about the youth. And the anchor youth spaces, they can also access the ISP services.
MLA Hilton.
Thank you. I think sometimes we lose a little bit of focus on the positives because we know that people are struggling. We hear that in our offices, and it is nice for us to have options and places to send them, many of them supported by the framework and the grants that your organizations provide. And hopefully we'll continue to see that and continue to see more investment in mental health and addictions as we move forward. I know there's many more organizations that I'm sure you're getting proposals from to help solve some of the issues or to work with some of the individuals in our community. So we're really supportive of the work that you're all doing. And like I said, this work is great. But what about the clinical space? When someone needs a higher level of support, I know that some of my colleagues have touched on that, but if they need support from a clinician or a psychologist, can you just elaborate on what that connection looks like?
ADM Stewart.
Ask
Ms. Vezina.
Susie to speak to that.
So if individuals are looking for help, the immediate would be the crisis line if it needs to be right away. So we have a 188 number, and we also have 988. Another way, and this is all self-referral. There is also the central intake line that folks can access. They'd receive an assessment, and then they'd be appropriately matched to the right level of care. 211 is a wonderful community resource. So not only would they connect you to services within mental health and addictions, but also any other needs related to the determinants of health that an individual may experience at any given time. There are a number of virtual services that are available directly online for folks. A number of helplines also available through 211 that folks can call to receive help. And there are also peer support services available through the intake line that individuals can access and that can be helpful in particular circumstances.
MLA Hilton.
Thank you for that. And just one follow-up and kind of from my previous work, I actually used to be the intake worker in Yarmouth for covering a maternity leave, and you know, you never kind of knew what was coming in the office door, but you know, you always had some very almost life-changing conversations with individuals, and hopefully more positive than anything. But just I know with the central intake line, that's relatively new in the past few years, and there was some bugs that in the initial startup, but I feel like I've heard good things about wait times in when individuals will be called back or if they're picking up live. Just can you share anything positive about how that process has gone and where we stand now?
Ms. Vezina?
So this data, it can be tricky because it's point in time. So MLA Lachance already had mentioned, you know, the data being a quarter behind can be discouraging for folks. So what I know to be the case at this particular point in time is that calls are being answered within 3 minutes, typically for the crisis line. We know that for an intake appointment is typically being returned, if not answered live, within 3 days, and that we are up to 80% of folks being given an appointment time within that 28-day barrier. There are always improvements that we're making. We are, through the strengthening of the continuum of the service and proper matching folks to the appropriate level of care, trying to make a greater impact there and trying to reduce those wait times.
Thank you. MLA Robichaud now? Okay.
Thank you, Chair, and thank you everyone for the information that was shared today and the questions that were answered. So I know that new programs can be difficult, and of course you need to learn and you need to adapt. So how will the Office of Addictions and Mental Health continue to strengthen collaboration with community organizations to ensure universal access remains sustainable and effective across all regions of the province?
ADM Stewart.
To your point, though, the Insured Services Program, it is a first in Canada, so there have been learnings, and we are continuing, I guess, to adapt. But with specific to your question about the communities, the position that was created within the Office of Addiction and Mental Health, we have the community liaison role, and that individual is in regular contact with the communities, and that I see the office sees as plays a very vital role, because the input from those groups really informs the work that we're doing in the office. I would like to pass it over to one of my partners here at the table, maybe to speak a little bit more about their role in informing.
Who would like to speak?
I can.
Sure. Mr. Guest?
We have a process where we meet with a community on an ongoing basis through the year. As part of our work, we do community-based needs assessment, and we take the information from those needs assessment, but also the information that we get on the evaluation from the grants that we provide community-based organizations, and that becomes part of an annual report that goes to the department every June. And so it's very much the voice, we write it as the voice of community going to government. So it's very much us passing their perspective on. And so that would be one mechanism that we use.
Thank you. MLA Robichaud?
Thank you, Chair. My next question, well, I'm from a rural area, and we do have a great medical center in Clare, and we're also there's also resources in Yarmouth, who neighbours our constituency. But how is the office planning to address gaps in access to rural and remote communities to ensure universal mental health and addictions care truly reach every Nova Scotian, so specific to rural?
ADM Stewart.
We're working to provide access to all Nova Scotians as close as home as possible. So again, it's back to the continuum of care and the access that we're providing, whether it's through the virtual appointments, through the in-person centers. There's been 12 recovery support centers that have been opened across the province. That's through the Nova Scotia Health Authority, where people can receive clinical care. There's the hospitals and the emergency departments, the community clinics with our public partners in the health authorities. The anchor youth spaces we've already spoken about. They're a really key one for youth. A lot of on-ramps there and ability. But really, it's very similar to primary care. There's many access points, and that's part of what we're doing to build the universal access to the mental health care and addictions, is to have the various options. And through our the community wellness framework is to have those in community and in the rural communities. So it's not all just in Halifax.
MLA Robichaud with 5 minutes, 45 seconds remaining.
Thank you. No, that's all my questions, but it's good to see where we're at now and where we're going. Seems like there's a lot of good things. So I'll pass all my time to my colleague.
Thank you. MLA Corkum Greek.
Thank you very much, Chair. I'm always cognizant that on one hand, we have just 2 hours and we want to use our time especially well, but it's not 2 hours at all. You have all left your offices and the mound of work and duties and, your mission critical to be here with us today. And my question kind of loops into that and the use of time. And it is directed at our partners outside the department. Before politics, I worked for a nonprofit, It was a charity, in fact. It was not in health. It was in arts culture. I thought it was very important. I still think it's very important, but I cannot, even myself, begin to suggest that it is as critically important and essential as the work that all of you are involved in. But I know the cycle and how much time historically is tied up in the applications for funding to do the things you do. The reporting, and my gosh, you're just reporting on the last one when you are applying for the next one. And so I have my own opinions on the cost of all of this, pulling you away from mandate, adding additional challenges to keeping quality people, because you ultimately, you can say, I will do my best to keep you, you are great, but you maybe can't sign a contract beyond a certain period of time. What I'd like to hear from all of our agencies and foundations represented here is your description of how, through this framework and the ability to have multi-year funding, in fact, not my words, I'm a member of government, might be suspect with my opinions, but for you, how that change has made a difference. And if we can give all those who'd like to speak an opportunity, please.
So we'll start with Ms. Murray.
Thank you for acknowledging that. And I think for anyone working in a charity or mental health and addictions charity, that is very true, and all charities. And anyone who's in a senior position, you are not only spending a lot of time writing grants, we're also fundraising and going with donors, and sometimes it aligns, but other times you're really feeling taken away from your important work. So I had mentioned in my initial comments that receiving this grant for multi-year, it provided really a little more stability and the opportunity for growth, and the opportunity, as you so rightly mentioned, about staffing, being able to, we actually, to add a more personal note to it, even with one of the positions that we were able to create from this grant is an outreach worker and volunteer coordinator. And this individual is mainly tasked with working with our Building Bridges program, which has been notoriously underfunded because it's a one-to-one small group program and social connection. And actually, as this individual staff person has been meeting people, they're saying to her, this is more than 6 months, or this is more than a year. And when we explain how this funding has worked, just the positive feedback, so it's not only us doing that work of, and having some relief that we have some multi-year funding, but also, and I'm sure it's no different in other organizations, when people start hearing that there's been some investment in community-based organizations, and believe me, everyone does, we also want specialized care and more clinical care, but in the whole mental health continuum, care continuum, organizations like ours do play a role. So it has provided a sense of relief and, some stability. So thank you.
Would anyone else like to speak to it? Ms. Cunningham with 54 seconds remaining.
Oh, I'll be speedy. For us, it's allowed us to invest in technology to make the granting process more streamlined and not as manual. We're not working with Excel spreadsheets anymore. So by making a commitment to 3 years of funding to the Mental Health Foundation, we're able to use some of that funding to make it easier for our community applicants to apply, and in turn for our organization to process them.
Does anyone else like to speak to it? Mr. Guest?
I can't really answer the question because we're one of the organizations at this place that hasn't moved into the multi-year funding yet, and so we're still working on the annual. But the one thing I can say is that the funding has certainly helped us to be able to be a support for small community-based organizations that don't necessarily have the capacity and the people to do some of the work.
Thank you, Mr. Guest. We'll now move on to our second round of questioning, which will be 12 minutes per caucus. So we'll start with MLA Wilson.
Great, thank you. Thank you, everyone, for coming today on, I know, some of your great work firsthand, and so thank you. And thank you for taking time. I want to follow up on the question we heard from Ms. Cunningham. Her response is, what are the needs of your clients that aren't currently being met, and what resources would you need to meet those? I'm thinking particularly with CMHA.
Ms. Cunningham? Is that who?
I think it's a CMHA question.
Sorry. Ms. Murray?
Well, thank you for that question. I think we can all acknowledge, we certainly were here talking in our programming about social connection, loneliness, and social isolation, but also needs not being met. I mean, many people we serve are currently feeling more marginalized because of the fears of losing housing or I know someone who's spending 90% of their disability pension on rent, and trying to encourage that person to get the rent subsidy. But that right now, as we've been reflecting, Bev and I both, on the past many years that we've been here, we're so encouraged by some of the developments, like trying to provide more help at the right time. No door is the wrong door. But at the same time, so many people who, for example, where our local branch would serve are, experiencing, living in poverty and housing insecurity, and those struggles have just increased. I mean, that's not just in our organization. And I think one thing we do is we do provide that sense of belonging and someplace for people to perhaps take a little break from that. And in some cases struggling to get the right services in the mental health system. I mean, but that's, as we mentioned at the beginning, if we can provide more, if we can address the social determinants of health in a more integrated way, then perhaps when people we know who are living with severe mental illness or substance use issues, there would be more services for them to access. But I think that it's just a struggle. Like it's a struggle for a lot of the people we serve, just meeting their basic needs every day. That is that's not just here. That's across the country, but certainly in Halifax with the housing situation, we're involved. I mean, yes, we run Social Connection, but we also get a lot of calls from the public, and we end up, as people have no one else to help, like we will advocate individually in their behalf. So, trying to help people apply for the rent subsidy, trying to encourage people to get that, the disability benefit, for example. If that was a big issue for us last year, in that a lot of people who really would qualify for the disability tax credit, hadn't applied for it because they didn't pay taxes. And then when the disability benefit came out, I don't know if you're aware of that federally, which was $200 a month, we spend a lot of time because people were saying, oh, $200 would make such a difference. But the effort to struggle to go, or even if you don't have a primary care provider, that would be that was quite an effort for people. Some people did try to go ahead and get that, but it's financial, and yes, and some of the other struggles. I just want to quickly mention something that was asked about the accessing medication, and that was something that we were seeing a lot of for people not being able, not just people might come to our door or call, but also individuals accessing our programs if they lost their primary care provider and didn't have many clinicians working with them, such as a psychiatrist. They couldn't get some of their psychotropic medications renewed, and we were seeing people having to go to emergency departments. And that is just an area I want to mention that there has been some improvement because people can now go through that RAS program and quite quickly get their medications reassessed. We've just known some people that's really worked for them, and also even through Maple, because none of the local walk-in clinics will do that. But yes, those are just a few of the things that we've seen that people. It's just more of a struggle. I mean, we really have to address this. We really have to address the social determinants of health because it's. Would you add anything, Bev?
Well, I just think too.
Ms. Cadham?
Yeah, sorry.
No problem.
I think too, just like when people walk through our doors, and they know that they're getting a social connection, and it's addressing the loneliness piece, that component which is significantly vast in our communities across it's global. And I think just navigating a system is complex. And there's literacy involvement, there's cognitive involvement, there's mental health involvement, there may be some addiction use there. So I think coming where they can build a rapport with other people who are living in their shoes as well, but also getting the assistance from a team of individuals who actually understand. Everybody who works at our branch has some connection with mental health in some way, shape, or form. So they're speaking with people who have lived experience through relatives, loved ones, our own personal experiences. So I think navigating that system is something that we can provide and building a sense of trust and connection.
Thank you. MLA Wilson?
Thank you for the work you do. So I couldn't agree more. Obviously, affordability is affecting people's mental health. My last question is directed to the Assistant Deputy Minister. We heard that there are currently, correct me if I'm wrong, about 400 individuals involved?
ADM Stewart?
When you say 400, you're referring to the Insured Services Program?
Yeah.
And those, yes, there's just, I can get you the exact number, but it's just under 400. I believe it's 392 or 382 are accessing care with a private clinician through that program.
MLA Wilson with 5 minutes, 20 seconds remaining.
Okay, great, thank you. So 400 in a population of 1 million, it's not a lot. Which brings me to my question, what's the wait list time? And also we know from the data that shows that the time from seeing, so attachment to access varies, and in one case in the Valley, it's up to 88 days for first treatment, which is almost 3 months. So that's not discouraging, that's distressing. So my questions are, what are your total wait time for Universal? Do you have any set goals for the coming year? And what do you say to people who live in one area who wait 3 times as long as the other parts of the province for the first treatment?
ADM Stewart?
Working to continue to build access and to strengthen the system. We are working closely with our partners in the Office of Health Promotion, Recruitment, sorry, tongue-tied on that. We are working closely with them because recruiting in new clinicians is a very important piece of this, as well as working with our partners in the post-secondary institutions. So that is one way we are working, is to have more clinicians available. And as we've said earlier, we are the 1,000 more appointments. That is just in September, so that will continue to grow. Agreed, in the population our size, 400 is not a large number, but it is growing, and it will continue to grow. So we are continuing to invest in that and to work with our healthcare partners in that, and to recruit on more clinicians into the Insured Services Program.
MLA Wilson?
So 1,000 appointments is great, but what's the wait list and what's the target for 2026 for people? How many people to be actually attached, and seen?
Ms. Vezina?
I don't know that there's a specific target of number of people or appointments per se. We'll continue to add as we can. What I will say, our targets for wait times, however, is within 28 days for not urgent. So that's always what we're thinking of, and that this isn't the only solution to lowering the wait time. So the investments in the public mental health and addictions care system will contribute to that, as well as seeing people easier and doing prevention and recovery types of activities, such as our community-based organizations in the Tier 2 space, hopefully will prevent folks from needing the formal mental health and addiction system.
MLA Wilson?
I guess I'm looking for more specific goals, and that 400 people have accessed it, but how many people are waiting, whether it's 1,000 appointments or 2,000 appointments, and do you have any goals about the number of people you hope to try to get seen in 2026? Not the number of appointments, but the number of people that you want to get off that wait list.
Ms. Vezina?
Not specifically, because so much actually weighs into that particular answer. So ideally, if we could back up the bus and we were doing more prevention so that less people needed it, then the number of people needing the higher tier service or tier 3 and above services, there's benefits. So there would be a good news story of seeing that lowered in the situation where it's because we're catching things earlier. So there's too much context around kind of an ideal number that we would want to see in the run of a year.
MLA Wilson with 1 minute, 20 seconds remaining.
Again, I'm struggling with how do you determine how many appointments you create without a goal or describing how many people need to be seen. So here's the need. I haven't heard how many people are on the wait list. How do you determine how many appointments there are without setting a goal?
Ms. Vezina?
Again, the number of appointments would be dependent on when we hit that point where we are able to offer appointments to everyone who calls within 28 days. The number that would be, I'm not sure. So that's why the target is how long they would have to wait.
MLA Wilson with 40 seconds remaining.
So can you tell me and I realize it changes, how many people are on the wait list at this point for universal mental?
ADM Stewart.
I don't have the specific number, but we will get it for you. One thing I would like to make sure is clear as well is with the insured services program, people have a choice. So when they call, so I just want to make that there are people who sometimes say no, they would prefer to wait and talk to someone in the public system. That is something we are finding in the work we're doing, and it varies by region, but the majority of people on the wait list are being offered those appointments, and for a variety of reasons, they're saying no. Sometimes there's...
Thank you.
Okay.
We'll move on to the Liberal Caucus for 12 minutes. I'm Eller Rankin.
Thank you, Mr. Chair. And I do want to talk about hospice a little bit, but I just want to ask a question around, obviously there's a lot of people waiting to access mental health supports, and there's a lot of effort that's gone in through successive governments to expand collaborative care centers. Health homes are now a new term for it, but essentially different competencies in allied health, being able to provide the appropriate care that someone may not need to see a physician for. So is there efforts in actually providing the mental health clinicians within those health homes, or even psychiatrists within those health homes to take on some of those patients that are entering into those health homes and being attached?
ADM Stewart.
Yes, that is the intention. We are working, again, with the Department of Health and Wellness. There's a group of people there that are working on the health homes and that work, and we are part of all those discussions. Because one of the things, again, I'm fairly new into this role, and one of the things that really stood out to me is that mental health it's not like there's health care and then there's mental health care. It's all together. It has to be part of it. So when people come into emergency departments and they're in crisis, if you have a heart attack, if you have a broken leg, it really does have to be integrated. So it is really important to us in our office, and we're working closely with the Department of Health to make sure that that is all integrated within those home health hubs.
MLA Rankin.
Yeah, that's good to hear. I mean, I think there's been a lot of advancement, and the clinics around my area started with a doctor, and now they have 4 doctors and a few nurse practitioners and some family practice nurses. But I think what's missing is the mental health support, the dietitian support, the thing that we've been talking about for decades and just trying to get it done. And also pharmacists want to be a big part of this, and there has been credit to the government moving forward on scope expansion, and part of that was medication renewals. So as part of those medication renewals, are we talking with PANS about expanding those to those types of prescriptions that people are waiting for, that we're talking about today, that they're not attached, but can they go to a pharmacist? The Bloom program has been operating for a long time, and I know that's a navigating tool within pharmacies, but they are the ones that know most about medications. And is there an opportunity to, obviously there's guardrails in terms of not increasing what they're provided and safety around the actual prescription, but why not look at that opportunity to provide renewals for patients that really need it?
ADM Stewart.
Thank you for that. It is true, ensuring that Nova Scotians have the care they need when they need it, whether it's a doctor, a pharmacist, or whomever the health professional is. We mentioned earlier about the RAS program. That's the Rapid Access to Psychiatry program. That has been one way. Margaret had mentioned it, that we are able for those in crisis to have their medications adjusted more quickly. But we take your point, though, about looking into that with the pharmacists, and we'll take that back. MLA Rankin.
MLA Rankin?
Okay, yeah, I appreciate that. And I just wanted to touch on hospices because I did visit the Halifax location and saw like the incredible services they offer, and they do provide stuff like cover the grief support services, social work assistance, and other compassionate care, the music program. It's all great. I don't see them as a recipient of this community wellness grant, providing $750,000 over 3 years. And I met the staff, and one of them particularly spends a significant amount of time doing grant applications, and my colleagues spoke about a lot of that time that goes into that stuff. But I just wonder, how do you qualify the recipients of this grant? And would a association like Halifax Hospice be eligible to cover some of those costs that are important for their clients?
Ms. Vezina?
So the criteria for the community wellness grant were based on several things. So one of the domains would have been the determinants of health, and so in what way are the community organizations addressing the determinants of mental health within their project or initiative. We were looking at across the province in terms of services that are available in different areas of the province, urban versus rural, et cetera. So that was one of the criteria for the selection of the grants. And then we also looked at how proposals aligned with government priorities. And what the government was trying to achieve through primarily Action for Health and Universal Mental Health and Addictions. And so those would have been the three main ways that they were evaluated for the grants.
MLA Rankin with 6.5 minutes remaining.
Okay, and there's very limited access to hospice care in the province. And my understanding is that I don't have the exact figure in front of me, but it is, I'm sure Mr. Guest has it, but the majority of people that are waiting to access care never get it. So I want to ask the question, is it a priority this is mental health for humans on their last days. It's an incredible services that a lot of people don't get access to. And I just want to ask, in terms of the expansion opportunity specific to Dartmouth, there is a proposal before the government to look at a 10-15 bed facility in Dartmouth, and I'm just wondering if the Office of Mental Health and Addictions is actively supporting that support service expansion on the Dartmouth side.
ADM Stewart.
I will say that ensuring every Nova Scotian has the mental health support they need at the various stages of their life is at the core of what we are doing. I can't speak specifically to the project you reference in Dartmouth regarding hospice. I don't have any details on that, but it is an important area for sure.
MLA Rankin, 5 minutes remaining.
Yeah, thank you, Mr. Chair. And my intent is to make sure it's on your radar, so that's why I wanted to mention it today. And maybe I'll ask Mr. Guest to speak a little bit more to the importance and the capacity we have in the province right now to meet the needs of the population. And you probably know more about the specifics about the wait list of folks waiting to access the services and what. Maybe I'll ask a question. How many sites or beds would we need to fulfill the need and the demand that we have in Nova Scotia?
Mr. Guest?
So I didn't bring specific data associated with hospice today. I can tell you that Nova Scotians want access to a variety of options with respect to end-of-life care, whether it be hospice or whether it be supports to remain in their homes. And so I think whatever the strategy is, it needs to be considerate of all of those options available to them. And I think it also varies of where the person lives. Hospice at this point in Nova Scotia is currently offered in Kentville, Sydney, and Halifax, and so people tend to not want to travel away from their social supports in their homes, and so they do want supports in the community to be able to remain home. When you look at the High comparison of hospice beds per or palliative care and hospice beds per 100,000 population, Nova Scotia is on the lower side. I don't have the specific number with me, but you know, when you look at the comparison across the country, there is data to suggest that we do need more, but I can't tell you the specific number.
MLA Rank with 3 minutes and 15 seconds remaining.
Yeah, indeed, and I think Canada's on the lower side when you compare to especially the Scandinavian type countries. But I want to ask the question then with the last couple minutes to you, Mr. Guest. What else can the government do to better support the aging population and families in preparation for palliative and end-of-life care?
Mr. Guest?
Generally, what we hear from individuals and families in the community is it's the supports that are needed for them to stay home, and I think they vary from across the province. We do hear that there are sometimes inconsistencies in the delivery of service from area to area, and I think some of that is historical, where it came from prior to the health system being transformed into the health authority when there was the district health authority. Some of those historical practices are still kind of in place, and so as an example, and you know, I hear from Southwest Nova Scotia, if you want to stay home with a pain pump, that's more challenging than if you live in around Antigonish, as an example, just because of how that service is supported. And so I think it's, you know, some of what I hear is more consistency with access to some of those programs to be able to have those options. And people want to stay as close to home as they can. That's really the big factor that we hear from families and communities is they want the option to be able to stay as close to their loved ones as possible, and many like to stay at home.
MLA Rank with 1.5 minutes remaining.
Yeah, that's not much time, but I think I just want to end by saying I just want to support any project that helps expand that kind of service out. It's something that I think not a lot of Nova Scotians actually understand, but the facility is an outstanding one in Halifax, not on a bus route though, and I think the Dartmouth location would be able to provide that in terms of location that Mr. Guest spoke of, and there are efforts across the province, especially given that 50% of the costs are fundraised. People really care about it, and so if government can help with that funding that community is putting forward, I think that would be a worthwhile investment for Nova Scotians. I'll end there.
Thank you, MLA Rankin. We'll move on to the PC caucus, and we'll start with MLA Corkum Greek.
First of all, I want to thank, we were a little short for time, and folks were really concise in terms of replying to my last question. I really appreciate that. Another takeaway from my time in nonprofits was how often I was trying to find a way to fit the program. And I used to call this process pretzel making. And I'd like to say I became a pretty good pretzel maker, if I do say so. Not 100% effective, but from the outside, and this is the value of these committee opportunities, to have you here to confirm or to set straight, but from the outside, what I liked about the project stream of the framework was sort of its openness. So rather than, having to be X, Y, Z and fit those parameters, that perhaps this allows those organizations applying for funding to be as nimble as possible to the very specific needs of their communities. This was referenced a little bit earlier in a question to Ms. Cunningham about sort of some of the trends that you've picked up on, but if you can maybe just tell us a little bit more about the application process and that issue of like, am I out to lunch on this? Is there that kind of flexibility of purpose for the organizations themselves?
Ms. Cunningham?
Thank you very much for that question. Just a warning, I could talk about our grants process all day long. I won't. The great thing about our process is we don't tell communities or individuals or organizations what we think they need. They tell us what they need. So we allow every organization that's looking for funding support for a mental health and addictions program or project in their community to tell us what they need, why they need it, who it's going to help. So as far as the pretzel making, we try and, they're not the twisty pretzels, they're the ones that are straight sticks, to make it as simple as possible for the applicants to apply. And I think that's key because we have all different levels of organizations applying for funding. We have Kids Help Phone apply for funding, but then we also have an organization in Guysborough that's run solely by volunteers, and they're looking for peer support program in a church basement. So our program has to be accessible to all. And I mentioned technology a little earlier too. Technology has allowed us to make a difference there, and I see Marg shaking her head. Yeah. So we provide CMHA with funding. We provide Hospice Halifax with funding. And our goal in investing in technology was to make it easier and more streamlined for organizations to apply. So they're not wasting their time, trying to cross all the T's and dot all the I's and make it the way we want it. We want to make it more universal. So we've really made that a priority.
MLA Corkum Greek.
I thank you for confirming that. I can really, truly, on a personal level, appreciate every time that you can make something more effective and streamlined to simply get the support, the intended support to those activities. I also do recognize that evaluation of any government programs that we are obligated, as our duty, to understand the value and the learnings, because not everything that doesn't work out is without value. And so I would revert to the department, if you can speak to specifically that evaluation process, including, if you could, how that will also work as oversight to identify gaps geographically, community-wise, and so forth. Thanks.
ADM Stewart.
So with the community wellness framework, again, the accountability and the transparency is one of the key pillars of that. We've mentioned already the community liaison role, so that is a key person in that work. The quarterly meetings, we have status reports, annual financial statements. That's something we've done all along, but these quarterly check-ins and I guess keeping our finger on the pulse, for lack of a better word, to really understand what's going on in those communities with those organizations, that's really a key way to understand the gaps, not just wait for the annual report to come in, but to have the ongoing conversation and the ongoing dialogue with the groups to understand their needs. That's how we realize as well that the long-term funding is something that is helpful. We also have biannual expenditure reports and accountability reports that we do. So that all feeds into that process. Again, we've said a few times, but it's really early days for this work. It's been a big shift in how we are working in communities, and we're learning and we'll adapt. And as we hear from communities, and that first voice is really important to inform what we do, while also maintaining the right balance. We need the right balance of straight pretzels and the right balance of a little of the rigor to ensure the money is being well invested and achieving the outcomes we're trying to get.
MLA Corkum Greek with 6 minutes remaining.
Thank you. I will pass the remaining time to my colleague.
MLA Fedare.
Good afternoon. Thank you, Mr. Chair. Thank you for coming here today. I think some things are very clear. We're obviously moving in the right direction based on the things I'm hearing today. I'm glad to hear Ms. Cunningham talking about the multi-year funding, how it has helped with technology. Because I was a community person myself, I've served in different community organizations. I can't count the number of grants I've had to apply for and the number of application forms that we needed to fill. But I'm excited to hear what I'm hearing today, that we're presently supporting 23 community organizations who are in multi-level or multi-year funding, which has never happened before. I think that's a significant progress. I heard about the CAM and the ability to plan further as a result of that. So I think those are some of the major takeaways for me that I'm hearing today. I just want to ask quickly, because as a community person myself, I'm just wondering, we know that healthcare, mental health has its own stigma within communities, right? How do community members or people within who reside in a particular community become aware about the services that is being provided locally? Because obviously from one of the things that have been achieved through this community framework is to bring mental health care closer to the people. So how do people know that you do have this opportunity? So for example, if somebody comes, a constituent comes to my door, how do I direct them? How do I be able to tell them this is where to go? Anyone from, community organization can help me out here. Thank you.
Thank you. Ms. Murray?
Well, that's an excellent question. And
Ms. Murray?
Yes, hi. That's an excellent question.
Wasn't on.
Oh, an excellent question. And if someone came to your door, I mean, certainly it's already been mentioned. I would suggest that they, if you're not sure the specific community you're looking for, I'd suggest they contact 211, and also the website that hasn't been mentioned today that is with the Mental Health and Addictions Program. A lot of people aren't aware of that, and that is something that I know for many individuals in organizations a few years ago were actually invited to give input into that website, and it's the MHA. I can't remember the exact name of it, but we can get that to you. There is a lot of people don't access that website, which not only lists all the services in clinical and mental health and addictions, the formal system, but also lists all the community agencies and different programs that are available, and certainly all our local websites, CMHA. But really, 211, people don't realize that that's someplace you can go and just, often access any program. We receive not just our local Halifax Dartmouth branch, Canadian Mental Health Association, but also our provincial office and Colchester, East Hants, and Southwest Nova, but particularly our branch locally. We receive thousands of calls each year where people are asking, because because of who we are as a Canadian Mental Health Association, we don't just offer programs, we will offer navigation. And so oftentimes we get calls because we're known across the country. But, I think for many of the organizations, you will find that even if the person doesn't have the exact right number, as I know organizations like ours will help a person, right, Bev, access what they're looking for. And there's sometimes people will call us in crisis, and we have to give them the information of how to access services, and we will encourage them to reconnect with us when, a little bit down the road when they want to think about that. So, but those are some that I would suggest. I'll defer to others here.
Mr. Guest?
Just a couple of things that I would highlight. One is as part of our work each month or each year that we plan for with our grant from the office is a public awareness campaign. This year, our focus was on increasing grief literacy in the general population to try and create more of an understanding that grief is a normal human process that we will all experience in our lives. And so we're planning to do that again next year. The second thing I would say is that we created an online database called Healing Pathways Grieving Well. I gave you all a card on it. One of the nice things with the database is it allows an individual to go on, answer a few questions about whether you want service that's one-to-one, whether you're okay with it in a group, whether you're okay with it virtually, how far you're willing to go. And then what it'll do is it'll actually filter the supports and resources for you so that it can tell you which ones are available close to you within the parameters that you've selected. There's about 200 supports now provincially that we've got on the database, and it's growing all the time. One of the things we clearly heard from community, however, was particularly in rural isolated communities that don't have the same access to broadband internet, is they need the resources in a different way. And so one of the things we're looking at this year is putting out a print version that that we can make available in those communities that are more isolated. But those are a couple of examples of what we've been trying to do to make people aware of the resources and supports, particularly on the grief side.
Ms. Cunningham, there's about 15 seconds left. Sorry.
Ooh, speedy. Just to touch on what Marg mentioned, 211 works very well for us too, and where we serve all of Nova Scotia and rural locations, people will call us looking for service. We're fundraisers, but we help them by opening the 211 website from our desk and asking them the questions and then providing them with the information. It sounds simple, but it works.
Thank you. That's the question and answers over. Thank you all very much for that. I'd ask witnesses, is there anyone who would like to provide closing remarks? ADM Stewart.
I just want to thank the chair and all of the participants today for welcoming us here. I was very happy to be here and welcome the opportunity to highlight the vital role that the community organizations are playing in building universal access to mental health and addictions care here in Nova Scotia. The organizations aren't just filling gaps, but they're driving real change in our communities, and they're making more support available closer to home for Nova Scotians. They are part of helping government transform how we deliver care. This is a shift in approach. As we work with more partners and invest across the full spectrum of supports, from prevention and early intervention to acute services, our goal is to help people before they reach a crisis and ensure compassionate, reliable care when and where it's needed. But we can't do it alone. That's why we're working with the skilled professionals at the Nova Scotia universities, in the colleges, and the public and the private healthcare system, and as we heard today, with our community organizations. We're proud of the progress we've made so far, and we are committed to expanding the support options that make a difference for those in what matters most. Thank you to everyone working in this space across the province, mental health and addictions. We're changing how we deliver mental health support. It takes time, and we're making progress. But there is more work ahead. Nova Scotians can rest assured that we will continue to evaluate, learn, adapt as we move forward together. Thank you very much.
Thank you very much, ADM Stewart. Anyone else like to provide closing remarks? Okay, hearing none, I'd like to thank the witnesses for being here today. A very informative session. And seeing no committee business, the next meeting is February 10th, 1 p.m. here in the committee room. The topic is Early Years Programs from Public Health, and the witnesses will be Nova Scotia Health. Thank you all very much, and the meeting is adjourned.